Well,
Yeah.
well, hopefully we can get a few more spots and we can have a big reunion over there in Hawaii, right?
I know. Yeah.
Yeah.
Right?
All right, everybody, let's do this. Ready?
All right. Let's do
All
it.
right. Welcome to the Jetset Physical Therapy Podcast. We got our instructors in Hawaii. I'm going to let you introduce yourselves because I don't know all your credentials. So why don't you go first, Kendra?
My name's Kendra Harring. I've been a PT for 14 years, 15 years. I have my clinical specialty in geriatrics, and then also advanced certifications in vestibular rehab.
And I'm Brittany Valdez, and I have been a PT since 2013, I think. And I have my neurologic clinical specialty and also, extra accreditations in vestibular as well, and have been treating that, pretty much my whole career. So, yeah.
Awesome.
All right. Well, welcome to the show. I'm excited to take it as a student. And
Great.
we've had people signing out we're getting a lot of messages to sign up. People saying they were waiting for whatever this vacation to get approved. And so for those of you that don't know, September 26th on Oahu.
Mhm.
Right.
Yeah.
And we also have Jay Bott, co-founder Jay Bott here. Welcome.
Hey,
Yep. And I'm
what's up?
Randall. And check out our other courses if you haven't. We have Las Vegas, Krista Prado. We have Myofascial Decompression. And then
I've taken it. It was great.
yeah, it is a game changer course, right?
Yeah.
It really does change the way you do everything. I use it like all the time.
That's so cool.
Yeah. And then that's cupping, by the way. It comes with a free cupping kit.
Oh, nice.
We have hotel packages. And what else does it come with? Oh, well, Jay and I will buy you a beer at happy hour. Comes with that too. Yeah.
That's it.
That's
Catered
the
meal,
Whatever
seller.
money you're going to
breakfast,
definitely win in
lunch,
Vegas.
You know, CEUs. And then we're the one big thing I want to mention about some of our courses, not the vestibular one, but the other courses, we're AOT approved providers now. So AOTA. So
Yes.
our tennis elbow course and even our hopefully our myofascial decompression will be approved. We should be getting that soon. So yeah, excited for that.
Yeah. So you're going to get CEUs with
That's it.
this. All right. So let's talk dizzy patients because that's what I want to hear about. That's what the people want to hear. Okay. So just in brief conversations, you guys both know your stuff really well. So I think the general consensus with physical therapists is like we have patients and they're like, oh, like they lay on the table and they're like, oh, I'm dizzy. And then you're just kind of like, all right, tell me when it goes away. And then you continue. What are some questions that you would advise therapists? Maybe they're not certified in vestibular, they don't know how to treat it, but how can they ask the patient, like maybe to screen out to see if they are appropriate? Maybe send it to your fellow PT that knows how to treat vistid.
Go ahead, Kendra. You can go.
I mean, usually the first question I ask is like, when do you have it? When are you dizzy? And then my follow-up question is without using the word dizzy, how would you describe what you're feeling? And those can usually lead you in a pretty good direction. Would you add anything, Brittany?
No, I think that when PTs get someone dizzy, they get a little bit overwhelmed with all of the information that the patient's giving them. And so, yeah, just keeping it kind of tight to those specific questions and, getting the answer and just listening to the actual answer instead of all the fluff that's around it. So that's exactly right. Like, what makes you feel dizzy? Well, I feel dizzy all the time, but I really feel dizzy when I get out of bed, right? And
Mhm.
so that's really
Mhm.
what we're looking for. So, and then what does it feel like? Like, do you see the room spinning or does it feel like lightheadedness all the time? Do you feel off balance? So, yeah, those are pretty good questions. And then, for BPPV, we also want to know like how long is it lasting, the actual spinning. If someone says they feel dizzy all the time, then that's going to be different than,
Yeah.
spinning lasting seconds with position changes. It's usually what we'll hone in exactly right there what BPPV is. Yeah,
Yeah.
so those are good screening questions.
The
Yeah.
hardest part about vestibular stuff is so much is done in the subjective exam, which can be really frustrating. And that's why you got to kind of filter through like all the craziness and everything they want to say into the more important things and really push the subjective exam as much as they'll let you.
All right. My shirt looks weird on this, doesn't it? It
I
looks-
can't see you very well. You're like a.
Looks fine. Looks
Oh,
fine.
really? On my TV, it looks like it's. I'm
Well,
like
Jay's
the
already in
Matrix or something.
Hawaii, it looks like.
Yeah, I know exactly.
Yeah,
I'm already there. I set the mood.
All right. I'll just keep it on. All right.
No, yeah, keep it on. Keep your shirt on, Randall. You want to keep your shirt on.
It's a different course.
Yeah, exactly. Randall, we're not ready for that lab yet. I think it's one of the things I've seen just in vestibular stuff. The subjective is like really where you hone things down. So it's one of the areas that you really have to like your subjective has to be strong for that space. That's what I've seen. I'm a hack when it comes to vestibular stuff. I get, it's either BPPV for me or not, right?
Yeah.
And then it's just like, if it is, you do the maneuver and hopefully it works, right? You try it a couple times and hopefully it works. That's kind of the way I've learned it. But yeah, I mean, talk to me a little bit about that. What do you guys think on subjective? How important is that?
Yeah, I mean, subjective is the most important. Like, I have patients kind of get annoyed with me because I'm asking them so many questions. They're like, well, I just feel dizzy. And I'm like, well, that doesn't tell me anything at all. I need to know exactly when you feel dizzy, how long you feel dizzy, when did it start? When did it start? When do you feel it? How long does it last? What does it feel like? And so, yeah, this happened to me like last week at least 2 times. Some people kind of get annoyed when I keep asking them and asking them and asking them. And then I try to tell them in the beginning, this is what I'm trying to figure out, right? Like, you may have this diagnosis coming to see me, BPPV, but everyone has the diagnosis of BPPV when they come to see me. Like, it's my job to figure out if it's actually BPPV so I can help you, or if I can get you where you actually need to go, right? Or get help a different way. So it's actually the most important because that's just going to guide everything that you do after that. And if you just automatically think it's BPPV just from the referral that you get, and you go to do it and it's not, then you're stuck in a very confusing place. So it's good to know where you're going with the subjective. It's good to know where you're going to go with the objective after your subjective. So you're not confused after you find out, wait, it's not BPPV. Now what do I do? So, yeah.
And, we're always taught open-ended questions, right? But sometimes you do have to get really close-ended with them to figure out and filter through what really is going on. A common thing is I'm dizzy all the time. Are you dizzy right now? Well, no, I'm sitting. Okay, so you're not dizzy when you're sitting. Okay, can we get up and walk? Are you dizzy now? Nope, I'm not dizzy. Like you really have to hone in on and make them kind of choose yes or no. And that's why I say as able, because they do get pretty frustrated sometimes with us. Yeah.
What do you say to them? Do you say like, listen, I'm going to ask you some very precise questions. I'm not interrogating you. Do you have to give them a
just like just like kind of what Brittany said, like, explain to them right away that we're going to get a little picky with questions. If you can sense their frustration, just explain why we're doing things and asking all these questions, because there are really no major diagnostic parts of the objective exam other than maybe like a Dix-Hallpike. But what if the Dix-Hallpike's negative? Then what are you going to move on to? There is another diagnostic like test, but there's very few diagnostic type things in vestibular rehab.
That's actually one of the questions I had is, you have somebody subjectively, they're saying all the right things that it's a positive BPPV, I'm laying down, the room is spinning. But then you do the Dix-Hallpike and it's negative. Where do you go from there?
I usually ask, like, when was the last time you felt like the symptoms that you had? And that can kind of guide me like, oh, I had it this morning. So to me, that probably still is BPPV. Or actually, I haven't had it for a few weeks. Okay, so maybe it's not BPPV. So that's usually one of my first questions that I ask was, when was the last time you felt these symptoms?
If it's like a couple of weeks ago, you just say, okay, well, I guess it resolved.
I say,
Here's my number.
Yeah.
Sometimes, but
Yeah,
Mhm.
that happens all the
that's what I
time.
do.
So like,
Yeah.
like Kendra said, people have BPPV, but a lot of times it resolves on its own, right? So
Mhm.
like people come to us after a time because it hasn't resolved. But sometimes the doctor will put the referral in, or you might get a patient that said, "Oh, I got it," and you couldn't get an appointment for 2 weeks, and then they come in and it's gone. Then you just say, "Oh, well, it sounds like you had BPPV, and now it's gone. So here's my number. Feel free to call me, or here's the
Okay.
exercise if you feel confident. You can try it if it comes back again." But I
Mhm.
always
I
just
was
say,
kinda
keep
doing
it
the
in
right
your
thing.
back pocket. Yeah.
Yeah,
Use
because
the
we
right
know
thing.
the recurrence rate is high for BPPV. So more than
Yeah.
likely they will experience it again. And so just having the knowledge and education to know that it can be treated sometimes is really helpful too.
What are some things that a patient would say that would tell you, okay, this is not something that's physical therapy related? Like maybe I should send them to a doctor or, an ENT or something like that.
Yeah. So things like that are more vague. So so you'd suss out everything with your subjective. But if people are talking about lightheadedness, getting up and down, we can check orthostatics, but lightheadedness or feeling that way all the time could be, cardiovascular, it could be systemic, it could be sometimes like I had a patient who felt dizzy after he ate, right? And I'm
Mm.
like, okay, well, maybe that could be related to, your sugar levels or something medical where you're going to have to go and talk with the doctor. So that's one. And then, you have any other ones, Kendra?
Maybe he
I
drank
mean,
tons of
what's
whiskey
that?
with his dinner.
Oh,
Well, yeah, that too, actually.
I think we all have had that.
Not to me, to patients.
Yeah.
I'm kidding.
That's
I mean,
us, Randall.
just
I'm
Yeah.
yeah.
I'm
I
just
mean,
speaking from personal
honestly,
experience.
Yeah.
vestibular red flags are this similar to your normal red flags in a orthopedic exam, like especially like the 5Ds, like is there any double vision? Is there any other neurological symptoms that are happening along with it? We also have our this is going into objective, but our ocular motor exam that can point us into it not being PT related.
Yeah, like
Yeah.
something central.
Mhm.
Yes, yeah.
Yeah,
Can
you can
even
pick
be
up a lot of things there.
can even be visual, right? Like that's what I've heard. That it can be like eyeglasses or some
Oh,
of
yeah.
that, right? Right?
Oh, all the
Mhm.
time. Yeah,
Yeah.
Make
like
sure
or
the
like
glasses
somebody
are
got yeah,
clean.
or like
Oh,
somebody
really?
switched from bifocals to progressive lenses,
Yeah.
and they're really having a hard time finding that or monovision, like any changes in prescriptions.
Mhm.
Is the prescription even right? Like, when they went to the eye doctor, was their blood sugar crazy? So maybe their like even glasses prescription can be off too. But yeah,
Hmm.
you're totally right, Jay.
Mhm. Yep.
If you're gonna, so this is like a hypothetical. So you do the Dix-Hallpike exam. They're telling you like, oh yeah, I'm getting dizzy, but you don't see nystagmus. What do you recommend in that situation?
Well, this is the hot debate of vestibular rehab,
Yeah.
like even with
The
like the
crossroads.
higher ups, like some of them believe you have to have nystagmus in order to truly have BPPV. But I think Brittany would agree in our experience, you don't have to have nystagmus because you can suppress it. If you've had it long enough, you can actually suppress it. We're also looking, one thing they have added is, do they have a crescendo and a decrescendo of symptoms? So meaning, do the symptoms come on? Oh, there it is, but their eyes aren't moving. Oh, it's going away, it's going away. Like that's also what we're looking for.
Hmm.
And that usually means more of a positive Dix.
Got it. Yeah,
Yeah.
because the Dix-Hallpike is very similar to the, that test we learned in PT school that you never want to do, the VBI
Oh, yeah.
test. It
Yeah.
can also
I
make
mean,
you lightheaded.
like we're taught, like if you're ever concerned about that, you just don't do it, you know,
Right.
right? You need to send them to the doctor
Yeah.
to get like cleared. But yeah, hopefully
So
you're not seeing many of
so
those.
generally, like if they don't have nystagmus, but they are getting dizzy, it is a crescendo, then you're going to err on the side of the Epley maneuver.
Yes.
Usually, yeah.
Mhm.
Yep.
So,
Yep.
You know, it's easy. You treat it and then you retest it. Did it get
Right.
better? Okay. Yep. You know, so there is kind of like a good, like pretty quick feedback of whether you are barking up the right tree.
Got it. What percentage of patients would you say are Epley? What percentage is barbecue roll? And then there's some other maneuvers that I don't do because I like Gefani or something like that.
Gefani, yeah.
Gefani, yeah.
We're gonna teach it though. You'll see how easy it is.
That's why I'm excited to take this class.
Yeah.
There's a bunch of dizzy patients slipping through the cracks under my watch.
Well, under everybody's watch. It's just not you. Promise.
Yeah.
Yeah. But like how would you break it down? Like I know Epley is probably the most common. What about Gefani and barbecue roll?
For me, I would say like probably like 85, because I get a lot more like of the patients that come after they go to the PT and then they say, I don't know what this is. So I probably get a little more. But if I were to say, if I saw everyone, it'd be like 85% would be like posterior canal, would be the Epley. And then about 15% ish would be horizontal, maybe a little bit more than that. I think I see a little bit more horizontal canal or lateral canal. But I do the Gefani like 99% of the time. I don't think I've done a barbecue roll in a very long time, but it does work. I have done it before and it has been successful. But the Gefani just tends to be a lot easier and you don't have to put your patient prone, you know, your older adult in a big circle. So, and it works.
I can't wait
so
to
yeah,
learn
that
that
would
one.
be it.
Then.
Yeah. It's
Jay, do you know
Yeah,
Gefani?
that'll be a good one to learn for sure. I mean, historically, I learned old school, so it's like I've always done the whole Epley thing, and it's just like you get some of those patients, you put them down, and they're just like freaking out on the table,
Yeah.
and then you're just trying to. There's like so much you're trying to control.
Yeah,
you know?
reaching for you.
Yep. I've been like clawed.
Yeah.
I've been kicked. I've been, you know, like grabbing on. Yeah. It's like a wrestling match.
On that note, I always try, and I really do think it helps because I haven't got, I mean, I'm going to knock on wood, this is going to happen to me next week, but I don't get a lot of like vomiting, you know, emesis. I don't get a lot of people that really freak out unless I really tell them like, you will feel dizzy when we do this, but it's okay. It's just this, you know? And now, of course, if someone's like sensitive to motion, I know that they're getting sick. Sometimes I'll have them, you know, if they have an anti-nausea pill, it's good to have, you know, that their doctor has prescribed them, of course, you know, around, or of course, one of the little bags. But most of the time, you know, if they're prepared for it, I don't have them freak out too much, but really trying to educate them before you do it. And that seems to help me. So I don't know, but.
And also when you like lay them back and their eyes start beating, like if you see it, have them close their eyes. Like you don't need to, I mean, it is pretty cool to see. Like if you want to nerd out about it, like it is really cool, but also really good nystagmus, you can still see through the eyelids. So like just save them, you know, like it's really just, hey, it's going to pass. It's going to pass. Deep breaths. You're okay. You're okay. Just like constantly in communication with them is pretty key. And
that's a good tip. Yeah, I had this is just a story time, but I had a patient. I put her in the Hallpike and she thought she was falling and she grabbed my throat and just squeezed it as hard, and I thought I was gonna die. I was like, let go, you're choking me. And then ever since then, I'm like, have their head and I'll say, put both hands on your arm. That's going to be your seatbelt, and that keeps her hands off because I thought I was going to pass.
Yeah. Also, you can be in the back of them too. Like you don't have to be forward and tip them down. Well,
that's
we can teach that one.
Yeah.
I know they kind of teach it so people can grab onto their arms, but I actually prefer being behind because a lot of people think it needs to be a fast drop. It's not a fast, like, it doesn't have to be that slam
that's
that
true.
everybody thinks it is. Really just, it's about, the only time I'll go fast is if I think it's it and I'm not getting it. Like, I don't think like the crystal's dropping. That's the only time I'll like put speed into it if I need to. Otherwise, honestly, just putting that head back in the right position should draw it out.
Mhm.
And then, like, so what do you think about, like, they have genetic anomalies sometimes? Like, I've had, I work with somebody who's very experienced, or I used to work with somebody who's very experienced in Vestib. And I'd be like, I'm not getting it, but everything they're saying is Vistib. And then she would change the angle of the head. She'd be like, oh, they might have a genetic anomaly where their canals are at a different angle. I'm like, that's a different level than I'm at. But I was just wondering, are you guys at that level?
I mean, those are like case studies that they present at CSM,
Mhm.
like, yeah.
But there are people that have different, like the
Angles.
orientation is
Yeah.
different, and so sometimes I will try different angles with the head, and it does work, right?
There you go.
I
So you are
mean,
at that
yeah,
level, Brittany.
I guess so. Yeah. But yeah, so yeah, they might not be as deep. You have to kind of lift their head up a little bit, like don't turn it as far. So there is some different. So if I'm not getting it, but I know that it's right, I will
Yeah.
adjust the head position to see if I can get the nystagmus to come out in different positions. Yes. Oh, and different speeds, right? Yeah. Different angles. Yes.
Right. What number of visits are you averaging with like a very typical case of BPPV? Like, how many visits are we talking?
I mean, if it's posterior canal, like 2, like we hoped, and Brittany, correct me because I'm not an outpatient as much anymore, clearly. So posterior canal, like usually I'll see them and then I'll see them back within a couple days. If I can fit it in. Horizontal canal is a different beast, and that usually requires a little bit more visits, at least in my experience.
Yeah, I would agree. Usually I'll see a posterior canal within I put 1 to 2 visits, honestly. Sometimes I'll just do one and then
Yep.
make a phone call after and make sure
Yep.
that they're okay. And that their symptoms are
That's
gone.
great.
Yeah. If I trust that I, did it right, which most of the time I do. But no, or that I got it right.
Yeah.
Because there's kind of signs when you do
Yeah.
the Epley that you're getting it right. If they feel dizzy in the first position and if they feel dizzy in the third position, the crystal's going in the right way. And then they sit up and they might get a little dizzy. And then you try it again and it's not there, then usually I'll just see them for one visit. But the horizontal canal is a little more tricky, but every so often, most of the horizontal canals are like 2 to, if it's true horizontal canal, 2 to
Like
4
4.
visits,
Yep.
honestly. Yeah, that's pretty much it.
That's because it keeps reoccurring.
Also,
is that the reason
we
why,
get the
or-
wrong side. Like we learned in our class that we guessed the wrong side like 50% or 40%. I forget what the percentage was. Like, because it's really hard.
Could be 50. Should be at least
Yeah,
50.
no, exactly. So, and you think you got it, and then they come back and it's still bam, bam, bam. It's crazy.
So that's a good question too. It's like you try the same side again.
You just
or do
retest,
if they come back,
recheck.
you're like,
Yeah, the
Yeah.
Gefani makes it pretty easy to figure out. Like, yeah. That's our teaser for you to come to the class.
Yeah, there you go.
But like for those of you watching this show, I mean, if you have a really busy schedule, you're having a hard time getting follow-up visits in, Vestib is rewarding. You're going to get these people better in 1 or 2 visits, and it clears up your schedule. This isn't like total knee replacement where you're going to be seeing them for 12 to 16 weeks. This is one or 2 and done, right? So I always found when I was treating, it was a good way to kind of clear up those follow-up slots. I know everybody wants more of those.
Yeah, and like Brittany said, like if you think you got it, like if you treated it, it's a posterior canal, and on the second maneuver there is no nystagmus, then I would probably do a telephone visit, as a follow-up, like in a week, just to make sure they're doing well. And then also provide further education, because there are sometimes, I call it kind of post-BPPV syndrome, where the
Mhm.
BPPV is gone, but they
Yes.
still don't feel right. So that's
Mhm.
where a lot of education can come in just on that telephone visit too.
Yeah. Are you going in at that point with like habituation exercises and things like that?
Go ahead, Brittany.
Well, it depends. So I
Mhm.
actually will call them, and if they're feeling that, then I'll kind of instruct them, yeah, on habituation exercises. That's actually really good. So like, hey, I feel dizzy when they're fearful. Most of the time it's okay,
Yeah,
I
it's
don't want to lay
feared.
back. I still lay
Yeah.
on
Yeah.
3 pillows because I'm scared, or I'm still sleeping in my recliner. And then it's encouragement, like, you can do it. You're feeding into that fear, which is telling your brain, right? Red flag, red flag. So you're avoiding
Mhm.
it, and thus you're creating kind of this ongoing problem, right? This negative
Yeah.
feedback. And so we want to practice getting into those positions to stimulate the vestibular system in that position. Tell your brain, look, it's okay if we lay back down, right? And you do that, over and over again a few times, and usually it kind of resolves. But yeah, so if they're having that post beep, like we call it post
Mhm.
BPPV syndrome. It's this like, I feel dizzy when I go back, but it's not really like they feel really, really
Mhm.
dizzy. It's just they're fearful of going to those positions because, you know, you're seeing the room spinning around you. That's like a traumatic thing for people. It's telling your brain something's
Mhm.
wrong. That's what happens when you have a stroke, right? So
Mhm.
Yeah.
that
Yeah.
can happen when you're having a stroke. So of course your brain is thinking something is horrible, and thus we really want to break that pattern and that thing from happening like right off the bat, because that can perpetuate into something more centralized, and we don't want that.
Yeah,
What's
we,
the
Go ahead,
oh,
Jay. Yeah.
what's the literature on like research? Not research, recurrence. Sorry.
um yeah, my knowledge is it happens to people who've gotten it 50%. You're 50% greater to get it than the average person who hasn't had BPPV. So
Mhm.
yeah, I don't know if that's up. I haven't looked at the updated research,
yeah,
but
I
I
haven't
will,
looked at,
and I will let you know.
yeah, we
Okay.
will
But
for the
that's straight
Okay.
up.
course.
You're more likely.
I mean, it's up to, I think
Yeah.
it's even as high. I've read 60% too.
Yeah.
Oh
So
wow.
it's high. And then there's correlations, like usually people that are a little more anxious
Yeah,
tend to
I was
have
gonna
it.
say. Yeah, I was gonna. That was
Mhm.
gonna be my follow-up question. Is like personality types. Like, do you see this more with anxious patients? I mean, majority of the ones I've ever seen, they're generally pretty anxious to begin with.
Yeah.
And so it's like I'm just. I was wondering if there's any cause effect kind of thing with that.
There's a correlation, but also unfortunately it can lead into more like the chronic dizziness. Like you're more apt to unfortunately go down. Like if you replace the word chronic pain with chronic dizziness, we're
Hmm.
treating kind of the same thing. It's kind of the same education with that. And we're trying to stop that. And that's what Brittany was talking about, because we want to get
Hmm.
ahead of it, because we don't want it to go down that chronic route where the vestibular system's constantly on and constantly thinking about it. Because a lot of people, when they get, even if it's just positional vertigo, it resolves and then they're still dizzy. It's because they haven't gotten back to their normal life. Their vestibular system just got rocked and it
Hmm.
needs time to calm down. And getting back into general walking, vitamin D, sunshine, and also exercise, heart rate, getting our heart rate up to calm the system down. If you think about what you say to your chronic pain patients, you're actually going to say that to your post BPPV syndrome people too.
Got it. Okay. Cool.
Do you think it's like a chicken or the egg question? Like, because I would go crazy if I was and have to be anxious if I was dizzy all the time.
Yeah.
I don't know. That's what somebody told me. They're like, you would be, if you were dizzy all day, you'd be
I mean, there is a
more
chronic
anxious too. Yeah.
dizzy diagnosis, and
Yeah.
it's hard to treat. And if you do have anxiety, some of those other more central or chronic-y type um, diagnoses, fibromyalgia, irritable bowel
Mhm.
syndrome, they tend to go, unfortunately, down the chronic path as well.
All right. Well, you have any advice for clinicians that want to get started with treating some of this?
Come to Hawaii.
I know.
There's no better place to learn about BPPV than Hawaii.
Right?
Yeah.
Get on a surfboard, get on a boat,
Yeah.
right?
You'll be in the
Get on a
mix, like
plane,
looking
airplane.
at the ocean.
Yeah, exactly.
Mhm.
I mean, like, I think Brittany would probably say the same thing, but like the thing that really probably gave us confidence and the most education was Duke offers a course. It's like a week-long intense course. It's, I think, done at, is it Wash U yearly? And then they used to do it at USC. That's where we took it, like every other year. I don't know what it is now because of COVID. But it's a like 6-day intense
Yeah.
Wow.
course, and like
It's-
each day, like it's crazy, but you're gonna get so much information and the right information.
Mhm.
Yeah.
Yeah, and
I
then
mean,
after
mhm.
this weekend in Hawaii, I mean, you're gonna know what to do Monday morning.
Right.
So,
This is
the
going to be
apply-
a nice, short, like
Yes.
succinct. What I learned the best over my years of treating, and after that course specifically, because we took it a long time ago,
Mhm.
and then I've taken multiple other like ongoing courses, like more complex vestibular courses, but that one specifically, which I really enjoyed and really helped me, is that it is very succinct. So there's not a lot of people get really confused, and I'm going to say this again, by the fluff of vestibular, like it could be this, it could be that, it could be, but it's not
Yeah.
really fluff. It's either BPPV, it's either a hypofunction, or it's something else, right? Something central, let's say, or something vestibular, a Meniere's or something like that, or a
Mhm.
migraine, or there's other things it could be, but it's very simple, right? And so we'll make it very simple when we teach it. This is what you're looking for, right? When you go to work on Monday morning, it will be very clear, right? It's not this, it's not the, something crazy out there. It's either this, or this. And this is how you
Mhm.
treat it. And it's very, if you can kind of sift through the fluff of what the patient is telling you and know how to do this objective, you'll know what objective to do, and you'll be a lot more confident treating it when your patient comes in. And so that's what I will say. Like for me, it's very clear cut, and our course will be the exact same. It'll be very clear how to treat someone that comes in. When you hear all these things that they're telling you, it'll be easy to decipher what they have after you take our course.
Excellent.
Yeah.
Yeah,
Real
and
world,
you need,
real world experience in that too, right? So I mean,
yeah,
that's the key thing,
Uh-huh.
right? Like you guys will be bringing in
exactly.
all
Yeah.
the things. I mean, it's one thing to take a course; it's another thing to learn it from someone who's like, hey, well, just to what you're saying, Brittany. It's like, hey, I'll kind of like take some of the fluff out, and we'll really
Mhm,
focus on what you need to know.
mhm,
Which obviously, again, Monday morning you'll be able to put it to work.
And a
mhm.
lot of people want to know non-BPPV, but they haven't built the foundation of truly knowing BPPV. And that is our goal, is to build this course, be confident, comfortable in BPPV. And then we can do a part 2 where it's non-BPPV dizziness, because you've already built the foundation of what we need you to learn the other stuff.
That
Yeah.
sounds
Yeah.
awesome. Yeah.
And
Yeah.
personal
Great.
experience, I took a 4-day course, and when I went to work the next week, I didn't know what to do. I was like, I feel like more confused now. And then I took another course, and after about 3 or 4 hours into it, I was like, oh, okay. I was like overcomplicating it.
Yeah.
And I think
Yeah.
I've
sometimes
taken
less
those
is
courses
more in
before.
this case,
Yeah. Yeah.
So
And I think
one
people
day,
are scared of it, like they get
yes,
uncomfortable. But
clinicians.
yeah,
Mhm,
I
Mhm.
mean, but everybody should know how to treat basic BPPV. Like that's, I think, the biggest goal. And just be more comfortable, but you have to be open to treating the population as well. Don't just like put them on somebody else's schedule. If you truly want to learn it, you got to
Yeah.
do it a
mhm,
little more consistently, and you're going to build your confidence with that.
Yeah. I mean,
Yeah.
think about all those. I don't know. I just remember constantly, almost 3-4 times a day, my patients would be like, I'm dizzy. Don't ignore that problem anymore. You could be the
Yeah.
one that actually fixes it, or at least
For
Yeah.
sends them in
sure.
the right way.
And
Okay.
honestly, if you learn it, it's not I mean, and I'm not an expert. Like I said, I've created my own version, but
We're
you know.
basics. We're basics.
We're basic. Yeah, we're basic. But the ones you get, if you're able to treat those, I mean, it just makes such a huge impact on that person because
Mhm.
some of these folks are walking around with it for a few days and they just feel horrible, right? And so if you're able to
Yeah.
just knock it out really quickly, it makes a world of difference to these folks. So it's such a good skill to have, I think.
And not just days, people are walking around with it for years because they think it's a
Yeah.
part of the aging process. And like,
Mm.
that's what we also want to, debunk is like dizziness is not a part of getting older. That is not normal. So,
All right. Anything else?
Cool.
What are we gonna do in Hawaii? Like, after class? Any
go to
ideas?
Maui Brewery.
Okay. Yeah.
Get
That's what we're
dizzy
gonna
at
do.
Maui
Happy hour,
Brewery.
Maui Brew Co. Yeah.
Is
What are
that
you
what
gonna
you
get? Like
mean?
Mai Tai or
Oh
beer
no,
or
IPA,
water?
hazy. Let's do it.
Hazy IPA. Okay. You act like I should know that.
Brittany
will,
drinks
you
beer
will, Kim.
too. Yeah.
Yeah.
I do
All right.
like beer, yes.
Okay. Sounds good. A pitcher. We'll split a pitcher, us four.
There you go.
Yeah.
That sounds good.
Yeah.
It was recorded,
deal.
so now we know.
Yeah, yeah.
You said
Send
it.
us a full recording.
All right, you two. Well, thank you for being on the Jetset Physical Therapy podcast. Check out our other episodes if you want. We always interview our instructors, and then we do have some other classes up. So obviously, the most important is Hawaii, September 26th with these two, and
Come join us.
what is it? October 24th and 25th. We're going to be in Las Vegas with Chris DePrado for myofascial decompression, aka cupping. Right. And Jay and I are teaching inside a winery.
Oh, that's so cool.
Oh.
Oh, you on mute. You're on mute. We lost you, Randall.
You said you were teaching inside a winery, and then I couldn't figure out what it was, and I said,
Okay.
what is it?
There you are.
At least it wasn't
All
the part about splitting a picture.
Yeah.
Or taking my shirt off.
We have that recorded.
Oh, well, you could have left that out.
But yeah, okay, we will. Yeah, so we rented a winery out. One of the best award-winning wineries, Melville Winery. So if you want to learn about tennis elbow and when this is like a great class for OTs, because I know you OTs out there think once you reach the elbow that's where your jurisdiction stops. But we're going to teach you how to venture up to the scapula and screen out the neck, so you're not wasting time treating an elbow pain that was something else, and like maybe you can help their elbow pain with scapula. We're going to talk you all through it. So check out that class as well. And then plenty of we got some other stuff planned. So make sure to give us a like and follow. Join our email list. We got all kinds of stuff coming in 2027 too.
That's it.
All right. All right. Any last words before I end the show? Brittany, Kendra?
No, come to Hawaii. I think you'll learn a lot. I think it'll be good. Just tips, tricks, even for the novice or even the more experienced. I think everybody can take something from it.
Agreed. And we'll have fun. Promise.
Yeah.
We're gonna have fun doing it. Retreat style.
Okay.
All right, everybody. Take care. Thank you.
All right. Thanks. Take care, guys.
Bye.
All right, bye.